Welcome to our channel. Today, we're diving into a critical topic for ICU specialists. 10 things you need to know about platelet transfusions. Whether you're managing bleeding, preparing for procedures, or dealing with the complexities of transfusion reactions, understanding the nuances of platelet transfusions can make all the difference. Platelet concentrates are scarce collective resources. Platelet concentrates are derived from pooled whole blood donations or single donor apheresis and stored at room temperature with continuous agitation, but their storage is limited to 5 to 7 days, leading to potential shortages or waste. Demand for platelet concentrates has increased over the past decade, while the donor base has declined in many countries. Alternatives like cold-stored platelets, 14-day storage, and cryopreserved or lyophilized platelets, up to 3 years, are being explored, though the latter are mainly limited to research and military use. Cold-stored platelets have lower post-transfusion platelet count increments but exhibit enhanced hemostatic properties, making them suitable for bleeding patients. Platelet concentrates undergo storage lesions. Storage lesions in platelet concentrates result from manufacturing and storage, leading to structural and functional changes in platelets. These changes include the buildup of bioactive substances and microparticles, which can trigger pro-inflammatory responses. Longer storage durations are associated with reduced post-transfusion platelet increments. However, extended storage has not been linked to an increased risk of bleeding in patients. Prophylactic platelet transfusion reduces the risk of bleeding. Prophylactic platelet transfusion may reduce the risk of bleeding in hospitalized adult patients, but evidence shows high statistical heterogeneity, making the results uncertain. 2 RCTs in patients with hematological malignancies showed that a therapeutic-only transfusion strategy increased the risk of significant bleeding, though most cases were mild. Increased severe bleeding, WHO grade 3 to 4, in the therapeutic-only group was primarily observed in patients with acute leukemia and severe, prolonged thrombocytopenia. A study on neonates comparing different platelet transfusion thresholds, 25 versus 50 times 10 to the power of 9 cells, L, found a higher rate of death or major bleeding within 28 days in the higher threshold group, questioning the benefits of prophylactic transfusions in this population. Prophylactic platelet transfusion thresholds are heterogeneous. Prophylactic platelet transfusion thresholds in the ICU vary depending on the clinical context, with higher thresholds used for surgical and actively bleeding patients. In critically ill patients, transfusions are commonly initiated at platelet counts of 10 to 20 g/L, a practice adapted from hematological guidelines. Current European guidelines recommend a threshold of 10 g/L for prophylactic transfusions in non-bleeding critically ill adults. The recommendation for this threshold is based on very low certainty evidence. The dose of prophylactic platelet transfusion does not modulate the risk of bleeding. The post-transfusion platelet increment is used to evaluate the effectiveness of platelet transfusions, with the corrected count increment being the most precise measure. Poor post-transfusion platelet responses, defined as an increase of less than 15 gram/liter within 24 hours, are common in critically ill patients, particularly those with hematological malignancies and sepsis. Pooled and apheresis platelet products yield similar post-transfusion increments, but longer storage times are linked to poorer responses. In cases of refractoriness to platelet transfusions, testing for anti-HLA antibodies is recommended, with HLA-matched platelets used if positive, or switching to a therapeutic-only transfusion strategy if negative. Pre-procedural platelet transfusions. The risk of bleeding complications during procedures in thrombocytopenic ICU patients is not well defined. An RCT evaluated the effect of a single platelet transfusion before ultrasound-guided central venous catheter, CVC, placement in patients with platelet counts of 10 to 50 g/L. The study found that severe bleeding was rare in both groups, and platelet transfusions did not significantly reduce bleeding risk in ICU patients or when using jugular or femoral sites. Pre-procedural platelet transfusion may still be advisable when the subclavian site is used for CVC placement. Platelet transfusions improve outcomes in severely injured bleeding patients. The PROPPR trial compared high 1:1 and low 1:1 1:2 ratios of platelets and plasma to red blood cells in bleeding trauma patients. A post-hoc analysis from the trial showed that early platelet administration improved hemostasis and reduced mortality. Early platelet transfusions, administered within 6 hours, were associated with a survival benefit in severe bleeding trauma patients. This benefit of early platelet transfusion was further supported by findings from a large multicenter observational study. Platelet transfusions are not indicated for the reversal of antiplatelet agents. Platelet transfusions can counteract the effects of antiplatelet agents by improving platelet aggregation. However, studies have shown that platelet transfusions do not improve outcomes in patients on antiplatelet therapy with traumatic brain injury. Unexpectedly, platelet transfusions have been associated with impaired neurological recovery in cases of spontaneous intracranial hemorrhage. There is no current evidence supporting the modification of transfusion strategies specifically for reversing antiplatelet agents during active bleeding. Platelet transfusions harbor potential side effects. Platelet transfusions have immunomodulatory properties, contributing to interactions between hemostasis, thrombosis, and inflammation. Similar to red blood cell transfusions, platelet transfusions are linked to an increased risk of ICU-acquired infections. Pulmonary side effects of platelet transfusions include transfusion-associated cardiac overload and transfusion-related acute lung injury, TRALI. In thrombotic microangiopathies like thrombotic thrombocytopenic purpura, platelet transfusions can worsen thrombosis and are associated with severe outcomes. Caution is also advised for conditions like heparin-induced thrombocytopenia, catastrophic antiphospholipid syndrome, and hemolytic uremic syndrome. Platelet transfusions play a crucial role in managing thrombocytopenia in critically ill patients, whether it's preventing spontaneous bleeding, supporting invasive procedures, or as part of massive hemorrhage protocols. Yet, it's important to balance the potential benefits with the risks. While they can stabilize bleeding, secure surgical procedures, and improve outcomes in severe trauma, platelet transfusions come with their own set of challenges. From infections and pulmonary complications like TRALI to the risk of thrombotic events and even unexpected effects on neurological recovery in specific cases, these side effects require careful consideration. Understanding the delicate balance between these intended benefits and potential harms is key for ICU specialists in making informed decisions. Thank you for joining us today. Don't forget to like, share, and subscribe for more insights into critical care. See you next time.